Good afternoon, everyone. Please let me know if you can hear me. I hope that all of you can hear me well. Sorry, I was having a little bit of problem here, so I decided to sign off and sign back in. Wonderful, wonderful. Well, thank you very much, folks, for joining. I see that we have over 30 people already online, so it's 3 minutes after 12. I apologize for a couple of minutes of delay. It's fantastic to see everyone online. Welcome to the beginnings of our first webinar series on ethics and COVID-19. As I am sure all of you are fully aware, we are in the midst of a pandemic, and I always like to start meetings by hoping and wishing and sending everyone positive thoughts. I hope everyone and their families are safe and healthy and well wherever you are. We are, however, a strong community at GW and are happy and excited that many of us are able to work remotely and participate in both research, teaching, and service activities. This webinar really stems from the support of the Dean, who will be joining us shortly. Dean Goldman is on another line and should be with us very soon. But really to build on many of our faculty, staff, and student interest in the area of bioethics. There has been a rich tradition here at GW School of Public Health, as well as the larger university on ethics. And we are now trying to build on that tradition by increasing our programming, our education, as well as our research on these topics. And so I'm very excited that this webinar can add value, particularly in times of the COVID-19 pandemic. The goal of these webinar series, and I hope we'll be able to have one every 2 to 3 weeks. So please, and we'll try and make sure that we do them regularly on pretty much the same date and time so that it becomes part of your schedule. But at least this very first one, it's going to be more of a conversation. And I'm very excited that this will allow us to introduce a whole host of issues around ethics in the time of COVID-19, but also to request all of you who are participating either right now, which I hope during this session, to not only ask questions and give your reflections, but also give suggestions as to what are the topics you would like in terms of future webinars. We'd like to get a sample of topics that are of interest to the community, faculty, staff, and students, everybody inclusive, so that we can program future webinars under this umbrella of ethics in COVID-19. And have also ideas for particular speakers, whether they are colleagues from within the university or in the United States, or even abroad. You have colleagues whom you think might be interested in joining us in these ethics conversations. We would be very happy to hear your suggestions and try our level best to bring them to this webinar series. I want to thank my colleagues Lauren and Joe Creesh, who are providing technical support, and as long as the time zone will help us get those national or international experts in future conversations. So ladies and gentlemen, really the intent of these webinar series first is to keep the flag of ethics and bioethics flying, particularly in times of COVID-19, to generate interest in our community. And I hope that these will also serve not only to us to have a conversation, but for many of you to connect with each other on interesting topics, on interesting ideas. And who knows, that might be the basis of a course in the future, or it might be the basis of a research proposal in the future. And so this is really a space for us to have those dialogues and very much to identify future topics and interests. I'm delighted today that I have a group of panelists who will join me. And the way it'll work is that I request each one of them to make an opening comment, 3, 4, 5 minutes on the topic of ethics. I'm very much hopeful that Dean Lynn Goldman will join us soon, and I'll request her to make some opening comments around the issue of ethics and how that is critical part of public health leadership in the time of COVID-19. I'm delighted that we have Professor Melissa Goldstein with us, She is an ethicist. She's a lawyer. She's been in this field for a long time. And in a minute, I'll be requesting her to reflect a little bit about what she has been providing historically, but more importantly, right now, during the times of COVID-19. I'm also delighted to have my colleague, Dr. Paul Ndebele, our senior research regulatory specialist and faculty in global health, who has been involved in research ethics for a long time. And I'll request Paul to talk a little bit about the importance of ethics in research during the time of COVID-19. And then most importantly, after these opening comments, I'm going to throw the floor open for all of you to come in with reflections, with questions, with comments, with ideas, and we can engender a great conversation. I hope that agenda works for most people. We'll end promptly at 1 p.m. Eastern Standard Time. And if you are a student and if you certainly want to receive professional education credits, please have that document filled out and email Michelle. Michelle is going to put that up on the chat board, and we can get you your signature as well. So just to kickstart, I'm going to take a couple of minutes simply to remind us that we are building on a field of ethics which is fundamental to all things in public health. Whether you talk about public health education, you talk about public health research or public health service and policies. And for many of us, when we think about ethics, we often think of some cardinal principles in bioethics in particular. And many people have written about principles of ethics from Beecham and Childress, who have written a very famous book, all the way to Renan Gillen, who used to be talking about the principles of ethics from the Journal of Medical Ethics. But simply as a quick reminder that we talk about, for example, a principle of respect for persons. And the principle of respect for persons is fundamental to our analysis of what individuals should control about themselves. It's a respect for their autonomy, for their decision-making about things that happen to themselves. Sometimes this autonomy needs to be reiterated, especially in times of pandemics. And maybe we'll come back to that point about how autonomy can be exercised when you have policies that may pit it against things like welfare of other people, and how that debate will unfold. Another very important principle in biomedical ethics is that of beneficence, to do good. It is critically important that when we act, whether we act in terms of health policies or in terms of our research, how the principle of beneficence and doing good to others is foundational, because that is our ultimate goal, is to help others. And the sort of corollary principle, which sometimes is regarded subsumed under the principle of beneficence, but at other times is considered separately, is the principle of non-maleficence, do no harm. And so how can you ensure that your actions, governmental actions, institutional actions are doing good, but at the same time also minimizing harm? And this relationship between the two, which sometimes is called the benefit-risk ratio, is critically important in our discussions of ethics and in our deliberations around ethical dilemmas. And then finally, one more principle I want to talk about is the principle of justice, right? The principle of fairness. What is fair? What is due to each individual and to each group? And in COVID-19, we are actually COVID-19 is revealing some critical justice issues. And most recently, we have seen reports of how it's impacting vulnerable populations right here in the US and also across the world. And that vulnerability may be defined by age, by the presence of other diseases or comorbid conditions, but also by race and ethnicity. And this becomes incredibly important for us to consider in any ethical dialogue. So that was my opening comment, is a quick reflection for us to remember the principles of respect for persons or autonomy, the principle of beneficence and its corollary principle of non-maleficence, and the principle of justice, right? Whether you interpret that as distributive justice or social justice, we can get into those. And I hope that we'll keep those principles alive in our conversations as we move forward. So let me request my colleague, Dr. Goldstein, now to come in and talk a little bit about how COVID-19 has really fired up the clinical ethics side, and maybe give an example of two of the work that she is doing. So over to you, Melissa, for your opener.
Okay. Thank you for asking me to join you, Dr. Hyder. I have been looking forward to this. I also wanted to let everybody know that I have to leave at about 12:35 or 12:40 because I have a class to teach via Zoom. It's an undergraduate class on health policy that was, that I started teaching. I think my last residential class was on March 11th. So we've been doing this for about a month and it's working. There are some kinks, but it's working. So Dr. Hyder has asked me to talk a little bit about what's going on in clinical ethics. And clinical ethics is a little bit different than biomedical ethics when you think about it from a theoretical or academic standpoint. So those of us who are interested in ethics may think about the principles that Dr. Hyder just talked about and might write about them and might discuss them like we're doing today, and then write up, perhaps guidelines or foundational ideas, things like that, frameworks to deal with issues, but that's more in the academic sphere. Clinical ethics is thought of as much more active, that you're helping patients, families within clinical settings deal with things, conflicts, moral conflicts in medicine that come up every day. So an example might be, how does someone write an advance directive that honors his or her wishes and still thinks about the role of his or her family? And then at the bedside, how do various practitioners actually implement that particular advance directive? And what happens if there is no advance directive? And what happens if the patient's family cannot be found? Things like that. Ethics at the bedside, ethics within provider organizations, institutions as a whole. What has been happening during the pandemic, and many of you probably have read articles about this, is the conflict between what is happening at the bedside with individuals and the possibility of needing to treat a population as a whole. We ask our practitioners to think about the person in front of them, to think about how best to treat that person. What does that person need, whether it's a ventilator, whether it's a very potent opioid, to think about the person in front of the practitioner. What we are now dealing with is possible restrictions and limits on the availability of technology. Ventilators, but not just ventilators, perhaps pharmaceuticals, perhaps people, resources. How do we treat people in front of us? And what has happened is that these issues, either people have been confronting them, thankfully not as many here as we saw in Italy, right? And Italy was overwhelmed so quickly that they really didn't have a time to come up with frameworks. So the institutions at the forefront in the United States started thinking about these ideas then. Regional institutions started coming together, for instance, in the Seattle region, in the Massachusetts region, here in the DC region, started thinking about, talking about together how we would deal with particular shortages. But Seattle was a little overwhelmed. There have been discussions among, where the Seattle doctors talk to the people in the other regions trying to come up with plans ahead of time. And the ethicists have been involved in these discussions and on call 24/7, as much as, not in such dangerous roles as the health providers, but in how do we deal with this? How do we counsel the health providers? How do we help come up with frameworks? You might have seen some of these frameworks in the news. They've been covered in some of the newspapers. You might have seen some of them as very controversial. States come, who gets what, and then the states getting a lot of criticism about how this is designed. For instance, Alabama and Tennessee came out very early with their plans, and people with disabilities were left out when you were talking about who would get what ventilator if there was a shortage very quickly. So then the states retracted them and took them back to the drawing board and were thinking about them. What is happening now is that Various institutions are trying to come up with their own frameworks, and states are trying to come up with their own frameworks, and institutions are waiting for the states to come up with the frameworks because they would prefer to have the state, which actually has authority in these situations, to set frameworks. And what does the framework look like? They're trying to come up with numbers, and the numbers might depend on how sick the person is right now and how many issues the person has had throughout his or her life and what it looks like their prognosis is long term. How long will they live? For instance, do they have high blood pressure? Do they have heart disease? Do they have diabetes, type 1 or type 2? Have they had cancer? Are they a cancer survivor? What types of things have they already suffered, and what does it look like their survival will be long term? The problem here, and this is the last thought I'll bring up now, is that a lot of people with comorbidities, as Dr. Hyder said, all of these issues throughout their lives are also people who have been either minorities in the healthcare system or have suffered from various inequities all along the way. So they're in worse shape when they show up. And is it fair to punish them for being perhaps sicker now and not getting the ventilator or the scarce pharmaceutical when basically they have not been equal in the pool all along? The final issue is, what do we do with the healthcare providers, the first responders? Do we prioritize them higher in the list of who gets what so that perhaps they can recover fully and treat more people? Or is it actually fair, in the larger sense of fairness, to prioritize people who actually come up with the guidelines to begin with, who design the frameworks? So those are a few of the issues that we're facing. They're incredibly difficult, incredibly emotionally trying for the people who are implementing them. And it's a very difficult time for the providers for many obvious reasons, but this is one of them.
Thank you very much, Melissa. This is a great introduction to some of the issues, and I already see comments pertaining to clinical ethics, and so we'll come back to that in a minute or two. I see issues that are extremely important, and you're raising the issue of whether comorbidity should be considered against people, and whether the first responders, for example, right towards the end where you were saying, should they be given higher priority, are all important questions in ethics. So let's park those thoughts. By the way, folks, please put your comments, your questions, your reflections on the chat board. We'll go back to them as soon as we've gone around our panelists. We'll go back and request them to respond to it. So Paul, can you come in for a couple of minutes on research and ethics during this time? Paul, just check if you're unmute.
Okay, you can hear me now? All right, so thank you very much, Adnan, and thanks to Melissa for setting the pace by looking at some ethical issues in the clinical setting. So of course, when we look at research ethics issues, we are in a public health emergency setting, which presents several ethical challenges. When we are looking at the COVID-19 situation, there is need for a serious, balancing act of the risks to the subjects and also to research staff versus the potential benefits to the human subjects and also to society in general. Hence, the need to consider how we respond when we're looking at research which is ongoing, and also when we're looking at new research. But from a public health and also from an ethics standpoint, there is need to speed up research, which is aimed at developing some solutions for the COVID-19 situation. We need more research which is aimed at understanding this virus and understanding also the various human behaviors that worsen our situation as society. But more importantly too, there is the need to address efficiencies when it comes to IRB processes. There is also the need to speed up the clinical trial regulatory processes to ensure that we can actually come up with some interventions in the shortest possible time period. But we also have to realize that there are also expectations of the funders who are providing the funds that are being used for research. Unfortunately, when we look at our major funders, they've been very, very flexible with regards to how researchers should respond within the current environment. Now, when we're looking at responses relating to current studies, we've seen lots of studies being placed on hold. So these are studies that we have now deemed to be non-essential, but they are not non-essential, they are essential. But for now, we've simply decided to put them in a parking lot because we've said as society, we need to give priority to research which is addressing the COVID-19. So once we are done with this situation, we will then go back and continue with our various research projects. But over the past weeks, I've been dealing with lots of investigators who are looking into modifications for their various projects, which were actually aimed at minimizing or eliminating contacts with human subjects. This is from a safety standpoint. But we've also now had to come up with the requirement for PPEs, protective personal equipment, for some of our research staff who need to continue working on a few projects which are still continuing. Now, when we look at improving the speed of regulatory approvals, drug regulatory authorities are also giving priority to research which is aiming at COVID therapies. But right now, we are also seeing attempts to gather some data which is coming from different studies, so that at the end of the day, when you combine the data from the various studies, we can then determine if certain interventions are working, and then if they are working, then they can then be recommended for general use. Now, when you look at the modifications that are being proposed with regards to, for example, data collection, we need to also realize that some of these modifications might actually create some unintended ethical and also legal issues. For example, in trying to minimize contact with human subjects, investigators might decide to use Zoom or WebEx to collect their data. And yet this also presents some additional challenges. During the past few weeks, we're discussing security issues related to Zoom, for example, but there are also other issues related to collection of individual identifiers. In this particular case, where there are issues around the collection of IP addresses. There are also issues around recording of those interactions with the participants. There are also even issues around the background details. Right now, as I'm seated here, you can watch what's happening behind me. So the fact that someone is in their home environment, as an investigator, you're now intruding into their home environment. Those are some of the issues. But with COVID-19 also, we have seen in lots of studies remote processing of data. So research staff are now working from home, processing data, which under normal circumstances would have been processed within the GW environment. We are aware that within GW we have put in place lots of security measures aimed at safeguarding our research data. So this remote handling of data presents some data security concerns that investigators clearly need to think about. On the IRB side, we realize that the IRBs have allowed researchers to implement changes that are aimed at safety without necessarily seeking for IRB approval. So on the IRB side, we are happy that things have been moving fast. Now, in terms of giving priority to new COVID or giving priority to COVID research modifications, the IRBs have also put in place some measures aimed at ensuring that for those who intend to introduce new questions that relate to COVID-19, those modifications can be processed by the IRBs in an expeditious manner. When it comes to new studies that relate to COVID-19, the IRBs are also giving priority to these. So basically, we are saying as society, we are responding directly to the COVID-19 situation. Now, when it comes to applying the principle of justice in research, the burdens and benefits of research, there are also issues around selection of subjects for promising therapies. Once we start talking about, some promising therapies, we are conducting research on these. How do we fairly select subjects for those promising therapies? And on the international scene, how do you select countries and populations for large clinical trials? Recently, during the past 2 weeks, people were discussing about the French investigators who were suggesting that clinical trials should be conducted in Africa. And yet, right now, when you look at the COVID-19 situation, every country is actually a good candidate for a COVID-19 clinical trial.
Great. Thank you very much, Paul. This was a plethora of issues on the research ethics front, and I particularly want to come back to your last issue about positioning clinical trials. You've heard of now, from my perspective, a quick introduction. Melissa's on the clinical ethics side and Paul's on the research ethics side. I'm going to now go to the chat board to see what people are commenting and reflecting on. And maybe I'll bring in Melissa on the first comment here. Melissa, there's a very interesting comment that Ramin is asking, really around duty of care and the importance of duty of care, particularly if, and you mentioned frontline staff as well in your comments, Melissa, when they're not supported by their own systems, they don't have PPEs, and yet they're supposed to provide care. Do you have reflections on that particular element?
There have been instances when healthcare workers have opted out of caring, and some of them have faced employment problems with their employer. From an ethical standpoint, there is a duty to care. This is what providers are asked to do. This is what providers sign up to do when they are learning, when they're studying, when they take an oath saying that they're going to take care of people. But they are all human as well and have other duties. They have duties to their families, they have duties to their children, and many of them are very afraid of getting sick themselves or taking home the illness to their families, to their children, and what happens then. So people are facing this conflict within their own families. Many healthcare workers, if there is another person to take care of their children at home, are not going home at night, or they're going home to only their basements, or they're spending the night in hotels or the dorms. So here at GW, we have healthcare workers staying in the dorms now. It's taken a while to get that up and running. Many hotels are also housing healthcare workers across the country. So it's an internal conflict that people are dealing with individually. And then as managers, as employers, how do we want administrations to handle this when individuals feel the need to be at home taking care of their families or to not get sick themselves? Or what if the healthcare workers are in high risk groups themselves, right? What if they have comorbidities that they've had throughout their lives? What if they're diabetic or have high blood pressure or at increased peril? On the other hand, we have retired healthcare workers that are coming back. We have people that haven't practiced for years and years and years who are coming back. We have orthopedic surgeons. We have dermatologists who are doing ER shifts who haven't been in an ER since their training. So we have all of these heroic people that are not normally on the front lines coming to the front lines to help. So people are balancing these needs in an individual way.
Yeah, no, I think that's absolutely so. So there isn't a tight answer, but I think that this dilemma between duty of care and also protection of one's own self-interest, right? So there is the issue of autonomy of the individual healthcare provider, as Melissa highlighted, that this is an internal struggle that each individual has to do, and then from an institutional perspective, rules and regulations could be made. This reminds me of a different time when, and Ramin, you will understand that in terms of asking physicians to provide services in the context of state perpetrated actions or in the context of torture, and what are the duty of care responsibilities of healthcare providers then. So different circumstance, but just to say that there are instances where the duty of care becomes really, really important. And in this case, particularly if there's a scarcity of context. Paul, one of the comments online is about humanitarian settings and the issue of how high-income country settings, in general, we consider donor agencies and rich governments. They should be supporting the quote-unquote low-income or developing countries. But how does one do that when the high-income countries are also affected? And what responsibilities do they have to look after others when they are being hammered as well in a pandemic? Do you have thoughts on that?
Thank you very much for that question. So basically, when we look at the situation in which we are as the world, basically every country right now is affected. But it remains a fact that there are some countries which are better equipped when it comes to the resources, when it comes also even to knowledge. So even when whilst all countries actually affected, that duty to assist the weaker countries remains present. But I also see here increased role for WHO to be working more in terms of assisting the weaker countries. I am confident that WHO right now is providing resources. I heard in the past weeks they were providing resources in terms of money and equipment to the low and middle income countries so that they can take some measures to step up the activities related to treatment and also prevention.
Yeah, thanks, Paul. I think one of the key questions really is this notion of justice extending beyond national boundaries, right? So many interpretations of the principle of justice have talked about what you owe to your own populations and then what you owe to other populations outside the national boundaries. In fact, there have been papers such as by David Fidler about what is the significance of a national boundary vis-a-vis healthcare settings and healthcare resource allocation questions. But I noticed a comment around following up from Melissa's conversation about how people who have quote unquote retired because of the pandemic are coming back into service. The question is now pertaining to those who are just graduating and maybe put into service far early. I also see that Dean Goldman has joined us, and I'm wondering, Dean Goldman, would you like to address this issue from an ethics perspective, both in terms of putting people into service who left service and putting people into service even before they are maybe 100% ready? What are the ethical implications of that?
Hi there. I think you can see me. I don't know if you can see and hear me. Do you? Am I on?
Yes, we can hear you and we can just see you. Yes, we can see a little bit of.
Is that better? Hi. Yeah, no, this has been a crazy day. I've been on one of these calls after another one of these calls. I don't think that we ever want to put people into service who at least don't know how to protect themselves. I think that we need to make sure that people have up-to-date instructions about, even things like the use of personal protective equipment. Adnan, you and I can still remember the day when doctors and nurses would refuse to wear masks and other PPE because of their sense that that would provide too much of a barrier emotionally between themselves and their patients. And there used to be far more transmission of disease between healthcare providers and their patients. And just in context of patient safety generally, it didn't used to be very good. And there were these attitudes that were very hard to break down. And so many people coming back from retirement, maybe people who were trained and practiced at a time prior to this ethic. And in fact, I still am sometimes talking to providers who are kind of, well, I don't really think I need to wear the mask kind of people. And so I think that it is important, not only from the standpoint of protecting them and their health and well-being, but also other patients and others, because you might be at one point in time volunteering and you're helping out and you're involved with screening people with potential COVID-19, but also volunteer physicians might end up being the people assigned to take care of other patients, people who are coming in for other emergent or urgent problems that nonetheless need to be seen and don't need a provider who is transmitting COVID-19, because providers are not only at risk, but they are also potential vehicles. And so I think it's important to keep that in mind. Our own students who we've sent in as volunteers, we went through quite a bit of effort to make sure that the people on the other end are, understanding that our students need to be adequately protected. I just sent Jean a video that HR here produced with help from nursing and us on how to don and doff masks, because there's also techniques involved in that. It's not just give someone a mask, it's how you use the mask. And I think we need to do everything to do that. But on the other hand, we can't be the completely, in my view, we can't be the completely paternalistic people also, though, who say, well, because they're a student, that they can't volunteer or they can't help. And in a couple of months, they're going to be professionals. I think part of our job is to teach them, because this is going to be going on probably for many, many months, if not years, as public health professionals. How are they to conduct themselves in their work, in their jobs? How are they to be not only protecting themselves and others, but role models within their communities? So I think that this is a part of constructing, if you may, the professional identity of our people. But back to Melissa's point about how some people who are volunteering may be beyond, maybe in high risk groups. Our vice president for medicine, the dean of our medical school, who is coming into work every day, is in a high risk group by virtue of her age alone. And she is not, she's continuing to be the captain of the ship. And that, in her view, is her first responsibility, not protecting her own health. I think that is something that, maybe is unique to people in medicine, nursing, other healthcare professions, but I respect it. And, I think she's fully informed.
Yeah.
So I'm not going to, and I don't think I don't think President LeBlanc would say she's fired if she wanted to, shelter in place at home. But, I think that there's a limit to kind of where we can make these decisions.
Yeah. No, that's a great example of that personal negotiation that individuals do between one's own autonomy. And if one is autonomous in decision making, then you can make a decision to say, yes, I accept the risk. But Lauren, your fundamental question about getting, let's say, graduating medical students early, which a number of medical schools are now doing, and putting them into the workforce. In fact, last week, the editor of the Journal of the American Medical Association has put forth a proposal that the incoming class of medical students could be given a 1-month course on protection and safety, and then positioned in public health departments around this country to support city, county, and state level public health departments to deal with COVID-19. And their proposal, which came out in the April 8th issue of JAMA, was really about basically trying to figure out the development of a new public health corps. And this new sort of, for want of a better word, cadre or army of individuals would then support the public health system in this country to deal with this, but after 1 month of training. In other words, you are enabling them, giving them the knowledge and the skill set, which is the right thing to do. And in our terminology for today, it's the ethical thing to do so that they can protect themselves. But I think it's a great point that you've raised. Scott, your question around is so important because it's about personal rights, and you have that is to anti-vax group and the overall health of the total population. And that's always been the case in ethics of vaccines, where traditionally many vaccines have depended on the fact that enough people in the community take those vaccines in order to protect the whole community. And that builds off notions of herd immunity. And so the question, what is the balance between giving the individual freedom to say, no, I don't want to take this vaccine, and the implications of that for protecting the wider population, is something that, a number of case studies have come out, and always challenging. But in the context of a pandemic, where laws of quarantine might apply, becomes more acute. And so the good of the larger good sometimes is taken as the decision, as opposed to individual liberty or individual freedom. But let me bring in Paul into this. Paul, from your perspective in terms of vulnerability, what are your thoughts on this question that Scott is raising?
Thank you very much, Adnan. So for me, in fact, I was thinking of comparing what has been happening here within the US and what has been happening in other countries. So, for example, in other countries, when they were looking at quarantine, people actually being quarantined in state facilities, right? To make sure that really there is no movement. People are actually confined to these defined spaces. And yet, here, because we've been emphasizing on these individual freedoms, we're talking about self-quarantine, where people are moving in their homes. And if you are in your home, you can actually get out of your home and go to the shops. So at the end of the day, what are the implications when it comes to the health of every other member within that society? So I think when we are done with this COVID pandemic, these are issues we are going to discuss and say, how do we strike a balance between individual freedoms and also in the health of the general populations?
Yeah, I think it's a great point to learn from other contexts and other countries as well. I sometimes fear that we forget to do that, particularly in these situations. But I'm wondering if Dean Goldman would want to come in on this, especially because she's a pediatrician, for those of you who don't know. And I know that pediatricians hold vaccinations very close to their heart. So what is the lesson in terms of ethics we can learn from that, Dean Goldman?
Could you please repeat the question, Anand?
Right. So we are talking about the ethical balance between personal rights, that is refusing vaccines, for example, in terms of an anti-vax group, versus the overall health of the total population, particularly thinking in the future if we have a COVID vaccine.
So, the edge of where we answer that question shifts around quite a bit. And most states, for example, do allow for a religious exemption to be made. But frankly, I think that's in a context of, if you have few enough exemptions that you nonetheless can maintain herd immunity and you don't have transmission of the disease uncontrolled in a population, that it's tolerable. So, for example, when California adopted a different policy, which was that anybody on any grounds could refuse to vaccinate their child, and then they had rampant measles transmission, then actually public health stepped in, got them to change the law to tighten up the ability to take restrictions and make those restrictions on a religious basis anyway, only solely. In the case of something like the COVID-19, I think it's going to be very interesting to see how that plays out. First and foremost, we don't know how effective the vaccine will be, and we don't know what kind of coverage we'll need to have herd immunity. If it's like the flu, where with all the vaccination that we do not achieve herd immunity. We still have flu transmission. And so we make it a very voluntary thing, and that obviously allows for a lot of people to die every year from the flu. So with COVID-19, we don't want this circulating in our community at all. So it may well be that the balance is going to be toward being as forceful as possible in trying to require each and every person to get the immunization, on the one hand. On the other hand, we continue to have, within our politics, a lot of respect for religious freedom. And so I'm imagining that that might be where the line would be drawn, but it's very hard to say until we actually see the circumstances.
Yeah, no, I agree. And Scott, just again in terms of reflection, in my previous life, I've dealt a lot with this in terms of motorcycle helmets. The personal freedom not to wear motorcycle helmets, and 6 states in the U.S. Reneged primary helmet wearing laws as opposed to other states that mandated primary helmet wearing laws. And the point is that when that individual who decides not to wear a helmet gets into a motorcycle crash and becomes needing intensive care, ventilator support, etc., the society in the end ends up supporting that. And so the implications for these types of public health decisions, where personal autonomy versus the good for the greater community is repeatedly comes in different contexts. So thank you very much for raising that within this COVID-19 situation. I do want to come back to another point, Ramin, that you raised, which I really appreciated, which is how prepared are individuals. And in the setting, you specifically mentioned medical training. And Danielle, you've mentioned as well this notion of limiting the number of individuals. And I think that's very important. In fact, right, even at the School of Public Health, we have developed an essential list of personnel. And the essential list of personnel is saying that, look, instead of 100 people being in our building at the same time, all we want are those individuals, and preferably even that on a rotation basis, because we are concerned about their exposure and therefore the probability of them getting the infection, in this case, COVID-19. So I think examples that you've talked about are a way of rationing and protecting. And there is some element of paternalism here because the institution is stepping up to the plate and saying, we need to protect our staff, we need to protect our faculty. So I think these are important things that we would, that is important to bring forth. But I think I'd really like to connect that and in the last few minutes to an earlier point. Maybe it was Ramin who was discussing this, which is the role of not just thinking about individual duty of care, but institutional duty of care. And as a health systems person, I think that's really important. What is the mandate of the health systems in each setting to do that? How seriously do people do that? And particularly when we go from public to private sector. What is the role of private sector to step up to the plate? And we've seen in this COVID-19, for example, the government using its arms to force private sector to produce materials that are important in this pandemic. So could we force hospitals and health systems to provide support, even if that wasn't necessarily their mandate? And I think that's an ethical dialogue that is really important for health systems ethics. I think, Paul, from your perspective, in terms of learning from international settings, any reflections on that?
Yeah, so I think when we also look at other countries like New Zealand, for example, in terms of how they've responded, you see that the state is playing a greater role in terms of ensuring that the actions of citizens are regulated. And so you also realize then that the impact of COVID-19 has been minimized as a result of the role that the state is playing in that particular case. But I also wanted to move, I saw there's someone who posted a question about religious freedoms, who is talking about the churches and the pastors that are bringing people together. But you can also realize that if you look at other countries, the police and the armies have actually been going out to the churches and the synagogues and the mosques and chasing people out, right? Using the powers of the state. So if you look at what has been happening here, people trying to find some excuses. At the end of the day, we need to discuss how far we can continue with those arguments about our individual freedoms versus the interests of society in general.
Yeah, yeah. No, I think this is a really important point. So maybe I'll bring in Dean Goldman for one final sort of comment, and Dean Goldman, you can use that time to also make any further comment on ethics and COVID-19. But I think this issue, which is really important for us, which is to influence decision making amongst other influential people. Sometimes we refer to them as policymakers, sometimes we refer to them as religious leaders. We have used in public health, we have theories around how to impact these decision makers and to help get their support in helping us for public health programs. But do you want to reflect a little bit about COVID-19 and how to do that in this case, in this pandemic situation?
Well, I think that we find ourselves in a very unique circumstance today, in that a lot of the action about the COVID-19 pandemic is in fact happening not at the federal level, where we're so often used to operating, but it's state by state, even in communities, businesses, the universities, we ourselves are looking at measures that we need to take. And that often at those other levels, there is not clear information by bioethics experts, and so if you are as it's going on across the country, if you are trying to make a decision on behalf of an industry that employs a lot of people in tech, your Amazon, you've got a lot of people working currently, you're trying to keep your workforce safe. What are they doing? Are they going to be tempted, to do seroprevalence studies on their workers, bring in occupational health? Are they going to be tempted to, just basically pick and choose? People are going to be chosen to work if they have immunity. Will they, be testing, some of these companies testing people for COVID-19 virus once the test kits are widely available and we actually have reagents, which we, right now it's all very limited. Will that result in the potential that some will be excluded from work? Will they be compensated? Will that be fair in the way that is done? And those companies don't have bioethics expertise. The states even. There's a compact right now, the northeastern states, that's getting together to figure out how they are going to, because the federal government is not exercising clear and certain leadership about how it's going to bring the economy back up. But who is really going to advise that? I imagine there's some bioethicists up in Massachusetts, maybe, and maybe in Connecticut, if they're part of this, that can help. But there's going to be inequities across our country, and even the access to bioethics advice. Let's talk about an ethical issue. Not every region of the country actually has the kind of expertise that we have, certainly in our region, that you might see up in the Northeast, that you might see in California and Washington. And I think that this is a real concern because of the fact of, in our country, of how this is being handled. Look across the world, and I think you're going to see even larger disparities in terms of the approaches that are being taken. And will people be stigmatized on the basis of not having immunity, for example? You can't work for me unless you have certain antibody levels. I'm kind of not completely hypothesizing, because I've been hearing people having these discussions already.
Yeah. No, that's a great point, and I think Ramin is just reflecting on that as well in terms of mandatory testing and what the implications for that is. And of course, today we haven't had time to really dig deeper into the issue that and one particular word that the dean used, which is the inequality expression that she used. We are all very concerned about the impact of COVID-19 being unequal across all population groups, and that some are being more disproportionately affected in terms of morbidity and mortality. But also, we haven't had the time to get into notions of stigma and discrimination as a result of COVID-19, particularly when communication and media around it portrayed it as if it was coming from specific locations or specific groups of people, and the resultant negative impact on those individuals who are all members of our larger of our larger community and our larger society. So there's a plethora of other ethics issues that we really haven't had time to even touch the surface. And I recognize that there are a couple of comments that I've not been able to get to. I think one of them in particular, around issues of democracy and debate and rights of individuals, those are huge comments that I wish we had more time and opportunity, but maybe for future webinars, we'll pick up on some of those issues. I'm getting the sense that at least one future webinar should really focus on some of the clinical challenges, both in terms of treatment and care, but also resource allocation. And there was a very nice paper by Zeke Emanuel and colleagues in the New England Journal of Medicine 2 weeks ago on resource allocation ethics during COVID-19. And maybe we'll see if we can get one of the authors of that paper to come and talk to us a little bit more and reflect with us. I'm also seeing some interest around humanitarian ethics and COVID-19, and maybe that's something I'll reach out to Ramin and Ron Waldman and others, and maybe we could do a future webinar on that. And then finally, I see this whole notion of how health systems respond to these types of issues. And maybe having a global perspective on that would be very helpful to see if we can get some international colleagues to join us in thinking about that. So thank you very much, ladies and gentlemen, in terms of participating here. In this last minute, I just want to thank Professor Melissa Goldstein, Paul Ndebele, and our Dean Lynn Goldman for joining me for this first webinar. But most importantly, I hope all of you, thank you very much for your participation. I know that there were many more of you than those who put comments on, but I hope that you will more able and more comfortable with putting reflections, comments, questions, even critiques. All of us in the field of ethics have been are very comfortable with getting challenges to our thoughts and opinions, and I very much really hope that we can continue this. So please look out for our next webinar on ethics and COVID with our speakers. It should be in about 2 weeks, I hope. Thank you very much for your participation, and thanks again to all the panelists for joining me today. Be safe, be healthy. Hope to see you all soon. Bye-bye.